Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. As you know, A Women's Journey strives to improve your well-being through health education. It turns out that HPV causes more cancers than just cervical cancer. Tonight, we are so pleased to be joined by Johns Hopkins scientist and physician, Dr. Cornelia Liu Trimble, Director of the Center for Cervical Dysplasia at Johns Hopkins. Her clinical expertise and research interests focus on the development of new ways to intercept cancers, treating pre-invasive cancer caused by HPV. So please use the Q&A on your screen to ask your questions to Dr. Trimble, who will respond during the last 20 minutes of tonight's conversation after her presentation. And our webcast will conclude at 8 p.m. tonight. I'd also like to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance. And you can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. Trimble. Dr. Trimble?
Good evening. Thank you for that nice introduction.
Thank you. Thanks for being here.
And I'm one of the OBGYN and also oncology faculty here at Johns Hopkins Hospital. Now, my goal this evening is to give you an overview of HPV, including concerns that I often hear from my patients, the new ones especially, who come to see me. And then I'll tell you about two different non-surgical ways to block HPV precancerous lesions from progressing to cancer. It's a good story. These are my thank yous, my shout outs. It takes a village to do this kind of work, as you might imagine. My biggest shout out, our biggest, goes to our families, our patients and their families. Thank you for your generosity and thank you for being part of the cure. Okay, the big picture. This is the big picture I want you to keep in your head. Did you know that almost 1 in 5 cancers on a global level is caused by a known specific infection? Yeah. And we know we have preventive vaccines for the 2 viruses that cause the most cancers. We have a good treatment for the third one, hepatitis C. So when I tell you that there's so much disease, the big picture is that I want for you to keep in your head is that, we should be able to either prevent these cancers by either using a preventive vaccine or to treat early disease with immunotherapies that you may have been hearing about. And that's what I'm going to be telling you about tonight. Okay, HPV 101, to get us all on the same page, please stop looking at Google. All right, normal cervix. This is what a pap smear looks like of a normal cervix. And don't be intimidated. What I want you to notice is that these cells are big. They look like Kleenex, pink and blue Kleenex. The little spots in the middle, those are the nuclei, the itty bitty pencil dots. And then the rest of those cells is full of cell stuff. We call it cytoplasm. Now then, the most common clinical setting is to have an HPV infection and a normal cervix, normal pap smear. I do want you to keep that in mind. If you have your first detectable HPV, do not freak. And I'll explain why. Everybody has seen HPV. Basically, if you've anyone who's ever had sex has been exposed to HPV. And the reason that everyone has it is because you can't tell that you have a virus. I mean, you don't feel sick like, if you have a cold or something. There's no itch, there's no scratch, there's no bump. And in fact, there's so much going on down there, if you will. It's not exactly sterile. That your cervical immune system is kind of going, oh, is this something I actually have to do something about? Or can I put it, like maybe 4 or 5 on my to-do list? And that's where it ends up most of the time, quite frankly. A very, very small percentage of the time, the HPV can cause a precancerous lesion, and that's what this looks like. What I want you to remember from this slide is how different these CIN3 cells look from the normal. They're dark, right? And that's because the nucleus is taking up almost all of the cell. They look like great big raisins or prunes. I should not be able to show you this last one in this day and age, but this is what a pap smear of invasive cancer looks like. This takes a long time if it's going to happen at all. We think that if a precancer is actually going to turn into a cancer, it takes on the order of 10 to 15 years. And it also turns out that not all precancers turn into cancers. We did an observational study a long time ago, and we looked at patients' diagnoses when they had a biopsy-proven diagnosis of the CIN3, and then looked at their tissue when we took them to the operating room to do the resection. And you know what? 15 weeks later, 20% of them had gone away. They had disappeared completely. So I'm going to be focusing my remarks tonight on cervix. We focus because it takes so long to go from the precancer to invasive, all of our screening strategies are focused on finding this CIN3. And don't forget, I'm going to be talking about cervical disease, but HPVs cause cancers of the cervix, the vagina, the vulva, the penis, anus, rectum, and head and neck. Okay? Some of the concerns that my new patients come in with, these are some of the common ones. I have HPV, I'm a bad person. You're not. I'm going to get HPV cancer and die. Please get off the internet. No, really, I want to take this off of your freak out list. I have HPV, there's no point in getting the vaccine. Maybe there is. I have HPV, I'm never gonna. Okay, let's keep going here. The first one, I have HPV, I'm a bad person. Well, you're not. And as I said, everybody has been exposed to HPVs, and there's nothing to be ashamed of. In fact, actually, you have HPVs all over your body. Don't think about that too much. But there's over 200 different types of HPVs, and the different families of HPVs like to go to different parts of your body. What is she talking about? For example, the family of HPVs that cause plantar warts, guess where they go? They go to the bottom of your feet. They don't go to your left elbow. They go to the bottom of your feet. And it turns out there's a family of maybe 15 HPV types that likes to live in moist, warm places. And so those are the ones we find in the genital tract. And those are the ones that are termed high risk. I wish they hadn't called it that because it's very easy to conflate high risk with a high grade lesion. They are absolutely not the same. These 15 HPV types are the ones that are most commonly found in the genital tract. I have HPV and I'm going to get cancer and die. Well, we just went over this time frame, and let me reiterate that the progression from CIN3 to cancer, if it happens, we think takes a really long time. But in the meantime, this is what cancer interception is about. We're going to intervene right here. We're going to block it from going from a precancer to go to invasive disease. And I'm going to tell you about our research. We've been developing 2 non-surgical strategies to get rid of the HPV precancers. One is by using immunotherapies. We're developing ways to use therapeutic HPV vaccines, which are a completely different beast than the preventive ones. Therapeutic HPV vaccines make killer T cells, which are programmed to find these CIN3 cells and eliminate just them, not the normal cells. The second is really crazy. We've repurposed Artesunate, which is an herbal compound, a plant-derived compound that the Chinese have been using for centuries to treat malaria. And it turns out that these precancerous cells don't like it either. And that's a great story as well. So here we go. Therapeutic HPV vaccines. Now then, when I started down this road, I had no idea anything about immunology. I wasn't a trained scientist. I wasn't a pre-med. I mean, I majored in public and international affairs and wrote a health policy thesis. And so when Drew Pardol walked into my office early on and said, "Do you want to do HPV vaccines?" I thought, well, yeah, sure. It seems like a doable thing. What did I know of? Here's one of those slides that's, 3 years of work and one slide. And this is the only mouse data I'm going to show you. On the left is a cartoon of a vaccine that TC, Wu, and Drew had constructed that targeted HPV-16. And on the right are mice. And guess which ones got vaccine and which ones didn't. Now then, this vaccine was amazing in this model. It prevented mice from getting the tumors, and it also treated these big bulky tumors. So sure, let's rock and roll. Let's do this in patients. So this was my first clinical trial. And what this shows you is that these patients got vaccinated at week 0, week 4, and week 8. And then at week 15, which is exactly the interval during which we had done the observation, I did the resection. Now, this was really bad because it didn't do anything in my patients. The immune responses, I couldn't measure them. And the rate of regression, the rate of the disease going away, wasn't any different from the patients who weren't vaccinated. Okay. So what did I learn from that clinical trial? Well, first of all, humans aren't big mice. But then, you kind of want to know why it didn't work. And so I went to my basic science colleagues and said, why didn't it work? And they said, well, it's not your job to think about the science. And I thought, oh no, that's not going to work. Oh my goodness. I'm not even on Outlook. Sorry, guys. But that didn't make me very popular to identify reasons for failure. And so put this last bit on for any young people that who are watching. Don't be intimidated. Don't let anybody tell you what you can think about or not. It actually, go ahead and think about it. And actually turns out to be a good thing a lot of the time if you're trying to figure out something that you haven't had training, because you ask really obvious questions. Now then, in one of my other lives, I'm a pathologist. I look at slides. And although I'm not a fan of the evil empire, Yogi was right. And this is what I saw in my patients. This is a low magnitude tissue slide of a patient whose lesion had not gone away. You don't need to be a pathologist to see the difference between the left side and the right side. So here's the CIN3. And you remember the pap smear I showed you? That's the dark cells. All right? Now then, here is normal. Remember those big poofy cells with the itty bitty nuclei? Right there. Now the issue is that this dotted line is the bottom of the CIN3 lesion. And the problem is that all those black cells underneath are the immune cells. And they're all underneath. They have come to the right place, but they just sat there and having a teddy bear picnic or something. They're not getting in to the CIN3. So I'm going to highlight here these little red wormy things that you can pick out maybe. You see? And that's what we look for when we're looking at your cervix during a colposcopy. It's this very specific picture of these vessels poking up, and you can see them here maybe in the middle of these. We call it mosaicism. That's what you're looking for. And what's happening here is that these new vessels that the lesion is growing are really sneaky. They're slippery, so the T cells can't actually get in and get into the tissue. So we knew that was one reason that we had to, one thing that we had to get around, not just make an immune response, but get them into the lesion. So we did. It took a while, but we did work out a vaccine that worked in humans. And another big question in the field was, if you make an immune response, how does it know where to go? Right? I mean, big is good, but because immune responses tend to stick around in the site where they were first activated. So Connie Liu, nice if you make an immune response, but are you protecting somebody's arm from HPV? And it turns out that vaccinating in the arm did indeed make changes, really pronounced ones, in the target CIN. So here's one of my patients, CIN3, before vaccination. It's quiet, there's nothing going on. Here's that dotted line, that's the bottom of the lesion. And this box, I'm going to show you higher magnification. There's nothing going on here. No immune cells, it's just da-di-da-di-da. She got 3 vaccinations, and this is 7 weeks at week 15 after her 3rd vaccination. Holy moly, there's all those black swarms of cells there. Those are immune cells, and they're organizing into these clouds. And they're everywhere. I mean, there's a carpet of them. And I'll show you a closer up look here. And it's swarming with immune cells. Here's the bottom of the lesion, and I want to point out a couple of things to you. See, they're getting in like, they're getting into the lesion, and you see these guys, the cells that are shrinking down. Like, I'm dying. That's what a dying CIN3 cell looks like. So it's working. These things are working. And what I also want you to notice is in this one above here, I submit to you that's the residual CIN3. It's maybe 100 cells across. And you look at that, and I thought, maybe it just takes an immune response a little bit longer to work. And so after I saw this a couple of times, we amended the protocol so that patients could have a colposcopy and have a look at the tissue at week 15. And then we could make a decision. If they wanted to put off the go, no-go decision from week 15 to week 28, they could wait until then to give their immune responses a chance to work. The other thing I want to point out is that by conventional means of defining success, and what I mean is complete regression or complete response, by that definition, this patient was a treatment failure. There's no way you can look at these things and come to the conclusion that these patients had not responded, right? 2 big lessons here. Therapeutic vaccination in the arm knows where to go. The immune response went to the target. And let's think intelligently about what we're seeing. This is called intelligent design of trial design. That was a lot to spend on that second one, but here's this third one. I have HPV already. There's no point in getting the vaccine, right? I'm so mad. I wish I had gotten it. Okay, don't be. And I'm going to tell you why. Based on 2 pieces of hard data. Now then, the earliest trials testing the preventive vaccines were dose ranging. They were designed to figure out the best dose and the spacing of it. So if you came in and wanted to go on study, and you were found to have already a CIN3, that didn't mean you couldn't participate. You were treated, you had a cone or a leap resection to get rid of your CIN3, and then you were randomized to either get vaccine or placebo. Now then, it turns out all these years later that treated patients who had gotten vaccine were significantly less likely to have disease recurrence than people who had gotten placebo and had not thereafter chosen to get vaccine. These are really big numbers. It's not anecdotal. So, yeah, it's not a bad idea to get vaccinated, actually. And my recommendation or suggestion is also based on another piece of data, hard data. You'd think that giving a vaccine to someone who's clearly already been exposed to HPV, it's not going to make an immune response. How could it? But in fact, it does. Colleagues at the Fred Hutchinson Cancer Center in Seattle wanted to know the answer to that question. And they got 5 adults who had very low antibody titers to HPV-16, and they vaccinated them. Well, guess what? The vaccine made immune responses that were up to 100 to 1,000 times greater than their own immune responses. That was a surprise. And what we think may be going on is that the immune response that your body makes is kind of wimpy. Remember, it was kind of thinking, oh, I'll put this off to make a response to it. And your own body's immune response doesn't necessarily bind when it sees the HPV again, is not neutralizing. So it doesn't prevent the HPV from infecting again. Whereas the immune response that's raised by the vaccine is a lot stronger, and the antibodies are a lot strong. And so they actually do prevent the HPV from entering. There's actually a clinical trial ongoing now. You can find it on clinicaltrials.gov, which is testing the effect of giving the vaccine to people who have been treated for high-grade HPV lesions anywhere down there. Because it really does appear that getting vaccinated, even after treatment for a high-grade lesion, is going to decrease the likelihood of recurrence. So think about it. This is information in the weeds, but let's step back, and this has changed how I think about things and how we all think about things. All of these infections and what have you, they happen in a tissue-specific way. What is she talking about? Okay, I'm going to use skin as an example. So I don't know if you can see my pointer, but this is normal, healthy skin. This top side here with the white space, that's the outside. And then this bottom here, that's the inside. And all of these brown dots here are immune cells, and they're lined up along the base of the skin. Okay, that makes sense, because up here, as we discussed, is not sterile. And so germs and bacteria, whatever, they can bounce around here. Okay, whatever, right? You don't care. But if the germs or bacteria or viruses or whatever actually make it all the way through the skin layer to here, then your immune cells are there, poised exactly where you want them. Boom! Don't go any farther. And these are in a tissue-specific way. So if you think about it, infections are tissue-specific. In the case of skin, for example, a skin-specific or mostly skin-specific infection, poison ivy, and your skin immune response is focused on ridding the skin of poison ivy. Now then, in the case of autoimmunity in the skin, it's a little bit different, but still the same rules you're looking at. In the case of autoimmunity, the immune system in the skin is kind of a little bit on fast forward. And so there's this constant sort of inflammatory response going on to your own self. And in the case of cancer, of course, that also occurs in a specific tissue, if you will. And I used melanoma as an example, but you can think of tissue-specific processes in other organs. And we're all thinking about the same things really, but from different perspectives. I think of it kind of as like blind men feeling the elephant. And it's important to bring people studying from all these three different perspectives, because we'll all have different insights. Okay, I promised I would tell you about artesunate. Artesunate is derived from the bark of the wormwood tree. It has been used by the Chinese for hundreds and hundreds of years to treat malaria. Now then, the scientist who figured out what the active compound was given the Nobel Prize in 2015. And yeah, the scientist is a woman from mainland China. It's her work. Millions of people are alive because of her work. It's approved by both the WHO and also the US FDA for first-line treatment for acute malaria. And what I mean to say is that we've given artesunate to people who are really, really acutely ill. So we know a lot about the safety and the toxicity profile. We've given it orally, like pill. We've given it as an injection. We've given it intravenously. And in little kids who are too sick to keep food down, we give it to them up their little bums as a suppository. It turns out that these pre-invasive HPV lesions don't like it. So we formulated initially the artesunate into suppositories that look just like the ones that we use to treat yeast infections, Terazol. These are familiar to many patients and also to their physicians. And like the Terazol suppositories, these are self-administered. And the first clinical trial we did, and it's been published, was we treated women who had CIN3, any HPV type, and each treatment cycle was 5 nights in a row. And this was amazing to me because the patients treated themselves. Did you just get a thrill? And the design was the patient would come in, she had a biopsy-proven high-grade lesion. If she had a negative pregnancy test, we would hand her a box of 5 of these things, and she would go home and treat herself 5 nights in a row. And then she'd come back 2 weeks later, tell us about whatever symptoms she may or may not have had, and do another treatment cycle. So we tested 1, 2, and 3 treatment cycles, and again evaluated at week 15. So 2/3 of them had gone away, no kidding. And in half of the regressors, HPV became undetectable. Glory, hallelujah. Non-surgical, self-administered. How good is that? Halfway through this trial, it became so clear that it was working. We also formulated it as an ointment and are testing it now to treat vulvar HPV disease and also anal disease. Imagine having a non-surgical treatment option for those areas. Even though it's the same cause, HPV, the disease has a very different clinical behavior. High-grade HPV disease on the vulva is a really mean beast. So right now what we do is we take it out surgically. Even if you have clean surgical margins, guess what? Half the time it comes back. And so to have a non-surgical option, it's just awful to have to keep on having your bits chiseled at. And to have a non-surgical option is just tremendous, to say nothing of a non-surgical option for disease of the anus. And I've also opened a compassionate use protocol, and that covers a lot of people. It has to do with people who have recurrent HPV high-grade disease, people who are immunologically normal by every single thing we know how to measure, people living with HIV, but also people who have who are organ transplant recipients or who have autoimmune disorders and have to be immune suppressed. And the good news is that last week we submitted an amendment to the FDA to expand the number of patients we can treat on this protocol because the results are so far really promising. It's well tolerated. People reported itching. It was the most common side effect. And you know what? My patients are so motivated. It's self-administered. It's really inexpensive to manufacture. It has almost no cold chain. Did I say it's self-administered? The reason that excites me, it's a wonderful thing here in the States and in any high resource setting. But imagine the implications in a low resource setting or in a culture in which women's health is not a priority or sometimes not even on the table. Just imagine. Having this kind of treatment option, now we have an opportunity to study the contributions of the vaginal microbiome. So we have patients whose lesions disappeared, and we have patients whose lesions didn't go away. And we have brush samples from their cervixes from before, during, and after treatment. So we can compare microbiomes between lesions that went away and lesions that didn't go away. And the idea is, if we can find a commonality in the lesions that go away, if we can find, a bacteria that's common, maybe we could treat that bacteria. If we could make that microbiome look more like the ones did in the lesions that went away, well, maybe we could make the lesions that didn't go away, maybe we could make those respond to treatment better. And I'm sure you can think of a lot of other possibilities as well, but that's just on the surface. And we've just gotten funding to start doing that. But we'll be doing that in collaboration with MD Anderson. Another thing that it makes me think about is it looks as if the artesunate is making an immune response right where you put it. Which means that the way that the artesunate is eliminating cells, it's scaring up an immune response that's specific. So this is patient specific. So could you combine artesunate treatment with something like a therapeutic vaccine, which is very specific, and use the patient's dying high-grade cells as a boost vaccination almost to the therapeutic vaccine? That boost would be totally specific to that patient. You wouldn't have to figure out, maybe you've heard neoantigens or, mutations and all that kind of thing. You don't have to figure out what they are because they're right there, and you can boost that person's specific collection of mutations or cell death or anything. I mean, that would be the ultimate personalized therapy for the precancers. And these treatment strategies are all for precancerous disease in HPV. We call them proof of concept, with the idea being that, okay, this can happen in theory in early stages of this disease. So the next step is how can we make that happen in disease that's more advanced? If you see what I mean. And that's going to take working with other treatment modalities. It's foolish to think that any one treatment modality is going to cure cancer, of course. Well, I'm going to wrap up here by returning to that list of questions that my patients come on with. I have HPV and I'm going to get HPV cancer and die. Repeat after me. Not all HPV infections turn into cancer. In fact, most of them don't. And I've just told you 2 reasons to have hope. And that last one, people come in and they swear up and down, I have HPV, I'm never gonna You know what? Don't even go there. I thank you for your attention. I'm happy to take questions. And if you're compelled, watch my TED Talk, Kicking Cancer's Butt. Back to you, Kelly.
Great. Thank you, Dr. Trimble. I like the name of your TED Talk. We'll have to tune into that. There's a lot of information. We've got great questions. So I'm just going to jump right into it. You're ready for this?
I hope so.
Yeah. So our first question is from Sarah. And her question is, please speak to the idea of clearing the virus. I'm going to just read that, and I'm happy to repeat it. I consistently see people confuse this with I am cured and ask things like, can I get it again? You shared that most people clear it, but as I understand it, it is not cured and it certainly can rear its ugly head.
Okay. People do want to be cleared of it and never see it again. I don't really think that humans actually clear or get cured of many viral infections. If you think about it, I think they kind of go dormant. I think that the viruses can become undetectable. I mean, if you think about it, you get chickenpox when you're a kid and you get over it and you go about your business, and then 50 years later, boom, you have shingles. You know what? That's the same virus that's been hanging out all these years.
Mm-hmm.
Some people get shingles and some people don't. Same thing with herpes. You have an outbreak and then it goes dormant. Some people never have an outbreak again. Some people do. And I think many people are trying to figure out where HPV may be dormant, and of course figure out what might make it active or detectable again. But I think, imagining that you're going to be cured of HPV, I don't know how to make that happen. And for my patients, it's unsatisfactory, I suppose, for anybody who's type A like me. But the reality is that if you have a normal pap smear and had a colposcopy and you don't have a high-grade lesion, so if you have a normal pap smear or a low-grade pap smear or ascus and detectable HPV, we actually don't treat that because that's not considered a cancer precursor per se. We consider those to be an HPV infection.
Mm-hmm.
So try to stop thinking about, I use the cure word very hesitantly, actually.
Right. Thank you very much. That also goes into our next question from Corinne. And she asks, if you've been advised that you have HPV, but are not symptomatic, and then is there a cure? And you've answered part of that question where it's not really a cure. It just goes into, quote, remission or
it becomes,
dormant.
Yeah, you can detect it.
Yeah. So if you are not, you said that you've had HPV but are not symptomatic, what should you do, I guess, is that question.
Well, that's the thing about HPV is it doesn't cause symptoms. That's why everybody has it. Right? If you don't feel like you have a virus, there's nothing to see, nothing hurts.
Mm-hmm.
There's nothing to suggest that anything is amiss. There's no discharge. There's no yucky anything.
Mm-hmm. But if you've been detected with it, you've been told you have HPV. Mm-hmm. I guess the question would be then, where do you go from there?
Well, you come see somebody like me.
Mm-hmm.
Are first detected, and I'll do a procedure called a colposcopy,
mm-hmm.
which is, don't stay on the internet. It's not like that. The purpose of that exam is it feels kind of like going to the dentist, only it's down there, because what I do is I'll put a speculum in. By the way, I warm up the speculum and we put lube on it. And that's the end of the nice things we can do. But, when I do it, the first thing I do is I'll get another pap smear because pap smears are not accurate.
Mm-hmm.
So I want another one.
Mm-hmm.
And then I use a dilute vinegar solution. I squirt it on, and then I temporarily stop making noise. And people should not be alarmed when it happens because I'm just looking. And the high-grade lesions have a very characteristic pathognomonic appearance. And I showed you one in that Yogi Berra slide. They're very dense white with that polka dot mosaic pattern.
Mm-hmm.
And what we want to do in that initial exam is to make sure that you're not actually hiding one of those in your cervix or vagina. And once that becomes clear that you don't have a high grade, then, and the clinical impression is that you don't have a high grade, then we're more comfortable that you don't have a high grade lesion. And don't think that because the report says high risk DNA, that you have a high risk or a high grade lesion. They are absolutely not the same thing. So try to dissociate them in your head. Remember that a high risk HPV is one of those highly common HPV types, if you will, found in the genital tract. And that a high grade lesion is a precancer. I'm not sure that clears it up.
No, I think that's great information. Thank you very much for that. Dr. Trimble, this is a question from Suzanne. When HPV reveals itself late in a relationship, let's say 20 years, 20,
Yep.
30 years later,
Yep.
How do you communicate this to a spouse? And how do you convince them that you did not cheat? And,
Yep.
you really didn't cheat. Actually, that's a great question.
Yep. I can't tell you when you got HPV. I mean, you could have gotten it decades ago.
Mm-hmm.
And it never showed up. I've seen HPV show up in widows. People have been widowed for decades. It's just really that it's probably been undetectable. And then for some reason it becomes detectable. I can't tell you that your spouse has cheated on you because they could have gotten it a long time ago.
Mm-hmm.
I mean, it doesn't hurt to have a frank discussion about it, but there's no way you could ever. I mean, it's hard to come to that conclusion.
Right. I guess maybe that a good suggestion might be, you would know better than me, but when you begin to have a relationship,
Yeah.
an intimate relationship, and I think with anything, you need to be just honest and open about, things that you know about yourself, if you happen to know that, and then you're just honest about it. But I'm sure that's a very difficult conversation to have with, in particular, someone that you've just met, or, so.
Yeah.
But I think,
yeah.
what do you think about that? Just being open and honest from the get-go, if you can.
Absolutely.
Yeah.
I mean, yeah, absolutely. Right. And, many people come in and ask me, should their partners get vaccinated? Absolutely. Totally. I mean, the head and neck HPV cancers, the incidence is rising exponentially. I mean, the curve looks like this, whoop. And it happens in heterosexual men. Not who you'd think necessarily.
Mm-hmm.
Heterosexual men. It happens a lot mostly in their 40s and 50s. We don't know how to screen for it.
You don't know how to screen for it?
We do not have a validated way to screen for HPV cancers of the head and neck. Mm-hmm. So you might as well, you know now that the vaccine can make a good immune response, even in someone who's already seen HPV. So go ahead, get vaccinated.
Right. So, which leads me to another question that we have by Julie. And speaking about vaccines, when it first came out with the HPV about getting vaccines, it was for, really, they were talking about young females who were going off to college. And, you get your series of 3, I believe, shots it was, and 6-month period every 6 months. And now that's changed, I understand. And you can tell us, one, what is the beginning age that you could get begin to get the vaccine? And also, what about males getting the vaccine and their age?
Yep. The target, if you will, age to get vaccinated. And I do want to just add that in the early days, Gardasil protected against 4 different types of HPV, protected against HPV 16 and 18, which together account for probably 70% of all high-grade lesions. Outside of the cervix, HPV 16 accounts for most of the high grades. And it also protected you against 6 and 11, which are the ones that cause genital warts. They have since come out with a vaccine that protects against 9 different kinds of HPV. So it's the original 4 plus 5. So even if you got the original 4 a long time ago, go ahead and get the 9 more. The target age for getting vaccinated is boys and girls from 9 to 11. The bonus is if they get it at that age, they only need 2 vaccinations instead of 3.
Is that for life? Vaccines for life? Or do you need?
That's what we think.
Mhm.
But if you can imagine, the vaccines have been around for maybe 15 years. I think it's fantastic that they have raised awareness of HPVs.
Right.
Yeah.
So
it goes up to age 45 for both.
Oh my goodness. Yeah.
The insurances will pay for HPV vaccinations for men and women up to the age of 45. Do it.
Mm-hmm. Great information. Our next question is from Rita. And is it possible to pass HPV in the birthing process?
That's a great question. To the best of my knowledge, when it comes up, it has to do usually with condyloma, which are big old warts. And, C-section is not recommended unless the baby physically can't get through the birth canal. So having condyloma in and of itself is, to the best of my knowledge, doesn't mean you can't have a vaginal delivery.
Right. Thank you very much. Dr. Trimble, Jody wants to know if a high-grade lesion is found, what happens next?
Well, if you have a high-grade lesion, the standard thing is that you're my sister, you can't keep it. And so it comes out in one of 2 ways. What I do is I'll take my patient for an outpatient procedure, and some people do this minor surgery in the office. I don't do it because I don't like using a sharp thing on a moving object. So we get the patient very comfortable. I do a really, really good exam, and that will allow me to decide whether to do a LEAP or a cold knife conization. And if the abnormal area is a lot in the endocervical canal, then I'll do a cold knife, which is an itty bitty skinny blade, to be able to take out just that area and not, a big old chunk of cervix. If the abnormal area is kind of out on the outer surface, then I'll use the LEAP to kind of not shave, but take off that part. Does that answer your question? The standard of care right now is to remove it surgically.
Yeah.
You could also check out our clinical trials.
That makes sense.
Yeah.
Our next question, Dr. Trimble, is from Bonnie, and another great question: does a hysterectomy get rid of your HPV?
No.
There it is. Flat out no.
No. Yeah. Remember, we don't know where HPV is, dormant. Even when we do a colposcopy or a resection, we're just removing the cells that we can see are abnormal.
Mm-hmm.
There's no way for me or anyone else to tell what cells have HPV but aren't abnormal.
Yep, because it's a virus. Yeah, I can imagine. Right.
Yeah. So, yeah. I mean, one thing I do imagine is, remember, we talked about how one reason that your immune system isn't so excited about or alarmed when it sees HPV is because when it initially saw HPV, it was not in a context of, oh my God, I have to do something about this. But I don't think you'll find it published anywhere, but in my mind, when I do a resection, in order to have the oozing or whatever stop, we use cautery, ball cautery to stop the spotting or bleeding in the surgical bed. And you better believe that causes inflammation.
Sure.
So I think that residual HPV is probably then presented to your immune system in a context of extreme danger.
Yeah.
But having said that, I would still recommend getting the vaccine.
Thank you.
Mm-hmm.
So, Dr. Trimble, our next question from Brooke. No, I just lost her question. Let me pull that up. She would like to know, lesions can come and go in the HPV world. So you can have CIN1, hold on one second, and then 2, and then to 3, and then go back to 1. So where does that leave the patient?
Well, typically we used to think it went in a progression from 1 to 2 to 3. And it's not at all clear that it does that. Remember that CIN1 is clinically kind of the same thing as a low grade. And it's kind of like it's an HPV infection. And we watch that. I know it sounds abnormal, but we watch that. Because we don't consider CIN1 to be a cancer precursor. Okay. Whereas CIN2-3, that's a different beast. You'll see some literature that separates CIN2 from CIN3. That's kind of difficult to do in the real world.
Mm-hmm.
And in theory, CIN2 maybe is more likely to undergo regression, but it's tough to make that diagnosis, actually. And by that, I mean, if you gave the same slide to 2 different pathologists, they might not both come up with CIN2.
Great.
Or if
Thank
you
you.
give the same slide to the same pathologist a couple of weeks later.
Sure.
They may not be. It's not an easy diagnosis to make, and which is why a lot of the studies and the diagnoses are read CIN2-3.
Well, piggybacking on that, Hannah would like to know, earlier you shared that high risk is not the same as a high grade lesion, CIN3. And
Correct.
Can you please elaborate?
Okay, once more with feeling. There's more than 200 different types of HPV. They're all over your body. You don't think about them. They're all over your skin. They're like, commensal organisms. And there are about 15 HPV types that prefer to be in warm, moist places, like the genital tract. And those are called high-risk HPVs. They're the most common ones found in the genital tract. And that was the basis for calling them high risk. I think that's a really scary thing to call them, but nobody asked me. And in contrast, a high-grade lesion is actually a cancer precursor. A high-grade lesion or a high-grade dysplasia or a CIN2-3, we pay a little bit more attention to that because all cervical cancers grow out from untreated high-grade lesions, CIN2-3, high-grade dysplasia. We think that takes, if it does happen, that process takes on the order of 10 to 15 years. That's on the basis of one very unethical study done in New Zealand a very long time ago.
Mm-hmm.
And we're not about to duplicate that study. So a high-grade lesion, some of them undergo regression, as we've been showing. But right now, we can't tell which high-grade lesions are going to regress and which ones are going to progress. So right now, at least for now, the standard of care is if you have a high-grade lesion, I'm going to take it out.
Right.
And so that's the difference between a high-grade lesion, high-grade dysplasia, is not the same thing at all as a specific family of HPVs.
Thank you.
Mm-hmm.
Dr. Trimble, so Kavria, she would like to know, did these therapeutic vaccines work for cervical HPV only or other types of HPV like oral and anal?
That's a great question. The therapeutic vaccines target, they're really specific. So the ones that we've worked with target HPV 16 because that's the genotype that's found most commonly in the high grades in the cervix. But certainly once you get outside the cervix, like in the vulva and other sites, HPV 16 accounts for most of disease. So that's why all of our immunotherapies focus on trying to target HPV 16. But my work has started with HPV disease of the cervix because it's, informative. Because early on we figured out that some of these lesions will go away without intervention. And so treating HPV high grades of the cervix has allowed us to figure it out, oh, that works, or that way didn't quite work, and here's why. And so we can use that knowledge to, of course, begin to treat high-grade HPV disease at other sites. You're exactly right. Of the vulva, of the anus, of the head and neck. Sure. And there are other ways to make killer T cell responses than vaccines, as you well know.
Right. Thank you.
Mm-hmm.
For our next question, we have about 3 minutes left. So this question is from Jody. Suppository would not be a preventive treatment for men or for women with HPV cancer somewhere like the throat, right? So
right.
Yeah.
Right. We're working on that.
Yeah, working on that one. Right.
Yeah. If somebody wants to, support me to figure that out, my email address is cervixdoctor@jhmi.com.
Wouldn't that be wonderful? Yeah. So our next question too is from Carol, and she's saying, if you already have HPV and let's say you're in your mid-40s and all, do you still recommend the vaccine? And I know you've talked about this off and on, so just to clarify that, if you have HPV and you know it and you haven't had a vaccine,
get vaccinated.
Get vaccinated, regardless. So it's not that it will reverse it because there's no such thing, but
it's going to treat.
But perhaps could help it become dormant, maybe?
Well, like I said, this is early days. We don't know how it's preventing recurrences.
Mm-hmm.
But the hard fact is that it does.
Right.
And of course, people are studying very hard to figure out how that happens. I mean, ideally, we would want to give people a preventive and a therapeutic vaccine at the same time, right?
Well, wouldn't that be wonderful? Yes.
Yeah, put me out of business, please.
Yeah. So, but again, and the other takeaway from that is if you got the early on vaccines, you would recommend going in and getting the other one, call it a booster one, or what did you call it again? That was
Gardasil 9.
Yeah.
The early one was Gardasil 4.
Mm-hmm.
Now we have Gardasil 9.
Mm-hmm. Great. Good to know. Great information. Elizabeth, and this may be our last question here. We've got like a minute. So how do we get involved in clinical trials?
Bless your heart. We're redoing our website, and if you want to help us out, that would be wonderful. I based a lot of my talk on questions from my patients. There will be a link that says to our research or to clinical trials, and you can do it that way.
Great.
Most of the cancer centers will have something like that as well, but there's, I think, not that many people working on pre-invasive disease.
Mm-hmm. That's a great way to end this program. Look up Dr. Trimble and get involved in those clinical trials. It would be wonderful. So looks like we are getting close to the 8 o'clock hour. So I'd like to thank you, Dr. Trimble, for this evening, and for all of you for joining us as well. And in the coming days, a video of tonight's live stream will be available on the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under Videos on Demand. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about future programs, conversations, and podcasts, all featuring Johns Hopkins physicians and faculty, brought to you by A Woman's Journey. In the meantime, we hope you will find our monthly email informative and engaging. Thank you again. Good night and stay well.
Good night.